So Crystal is a licensed clinical social worker with a private practice called Open Mind LLC in South Bend, Indiana. And since 2015, she's been a trainer of EMDR. So she teaches EMDR to clinicians and offers advanced workshops and consultation. Crystal is a certified internal family systems therapist and teaches the integration of IFS and EMDR through the
You got it. Yeah.
Institute. She's also certified in ketamine-assisted psychotherapy. So, Crystal, I'm going to turn things over to you, but I'm really appreciative that you're here. So
Thank you. Thanks, Lisa. Thanks, y'all. Thanks for coming, and thanks for all y'all online who are here. So, welcome. And I want to kind of get a read on the room. Does it feel okay? Is the volume a little loud, or is it okay? All right. So, well, first I'll just say, trauma is oddly my passion. I don't know why, but well, partially I do know why, because, you know, most of us who are in the trauma field come from trauma ourselves. So, you know, clinician, heal thyself kind of thing. So I've been doing a lot of research, as we call it, over the years in the trauma field. And just have developed an interest in trauma and how it impacts individuals, couples, and families, and groups, and communities, and all of that. So I can kind of rant on and on about trauma for a long time, but I'm going to try to keep it organized here with our presentation. And I want to see, so kind of who's in the room right now. How many of you are like therapists or clinicians? Okay, so most. Okay, all right, got it. And then what about like, you know, caseworkers, social workers, like you know, mental health workers that aren't clinicians, working with kids, schools, youth. Yeah, okay. All right, good. Medical, any medical staff in a medical setting? Okay, yeah, a couple of people. All right. Like law enforcement or community agencies like that? Anybody like that? Okay. What's that? Legal, yes, thank you. Legal, okay, that's what I was forgetting. What about religious or faith-based communities? Anything like that? Okay. And what am I missing? Teachers? Okay. Anything online, Lily?
We have a lot of social workers, clinicians. We have some students.
Oh, students. Yes, that's who I forgot. Students. Welcome, students. Okay, good. Interns, all that. All right, great. So we have a mostly clinical kind of learning population here. So I will be speaking a lot to, you know, kind of the treatment parts of trauma, but hopefully lots of background information before that will make sense as we get further along into the treatment and the kind of clinical world of things. Okay, so I'd love to know, like, is there anything that just feels like you really, really want to know and get out of this, that like, if you leave in 2 hours and haven't learned something about this thing, you'll be disappointed, or anything that feels burning question-wise right now?
Absolutely, this is something I neuroscience and trauma. I would understand a little bit more about how neurotransmitters like the hormones, like
Yes.
serotonin, how they are extensively impacted by trauma.
Okay.
And I've been reading like some different studies that were showing that when you experience trauma, it does cause some impairment with those particular hormones.
Yeah.
However, when they are impacted, what I was noticing is that every study I kept looking at when I looked at abstract, they kept saying the same thing. A lot of times it seems like we become overly focused on serotonin and dopamine. We forget that when serotonin and dopamine is off, it affects the cortisol, which affects the amygdala, which increases fear and anxiety. So there are people who are often sometimes will be diagnosed with things like with certain forms of anxiety, really it may be more of a neural type of situation. So we can learn some more about how.
Yeah, I think that's pretty much in there. Good. So just to repeat that, yeah, hormones, neurotransmitters, how they're affected, and then, you know, what are we missing in, you know, kind of classic look, you know, at the neuroscience research and things like that, and how do we understand how that impacts the amygdala, the fear centers, all that sort of stuff. Yes, I've definitely got stuff about that. Yeah, Lily.
Could you repeat questions for those online speaking here?
Yes, so that was kind of the hope, was neurotransmitters, hormones, how they're affecting the brain, how they affect the amygdala, looking at kind of the research and the science in the background around that and how that impacts brain function after trauma and stuff like that. So anybody else have something? Yes.
I work at Beacon Children's Hospital.
Beacon Children's Hospital, okay.
Wanting to take information to help nursing and medical providers to understand the impact of trauma on
Yes.
parents in Children's Hospital, so
Yes.
that they can have more compassion. So I'm hoping to
Yes.
take information to them.
Okay, so the comment there is working at Beacon Children's Hospital and hoping to take some information back to the nursing staff, the medical staff, about impact of trauma on the parents and the children and what they're going through. And yeah, good. I'm gonna keep that in mind as I go forward. Thank you. Others? Anything online coming through, Lily? Okay. Yes.
And one last question.
Okay, wonderful.
One last question. I would also like to understand, like, when we talk about neuroscience and its relations to two different things.
Yes.
If we have time for it.
Okay.
I don't know if these things are in there, but I'd like to learn a little bit more about neuroscience and its relation to addiction and how a lot of times relapses are consistently recurring, like recidivism rate in prison,
Yes.
because of the, when you start talking about serotonin, dopamine,
Yeah.
oxytocin, cortisol, and several other neurotransmitters and things like that,
Mhm.
how they truly impact addictions
Yeah.
and things like that.
Yeah, I don't have it. Okay, so the question there is about neuroscience of trauma and addiction. And
Yeah.
I don't have anything specifically in here about that, but I'll speak to it now that I know that that's kind of question. It's not my area of expertise, but I'll throw it in where I can. I appreciate that.
If you can,
Yeah.
you don't get to it, I understand.
Cool. Also, probably a great topic for another time. Yeah. Yeah, absolutely. All right. Anything else that feels important? Okay. All right. Well, let's move forward. So I have a bit of a pet peeve lately that I kind of groused about with some of my therapist colleagues, which is that lots of people go on TikTok and diagnose themselves with various mental illnesses and disorders and things like that. And the overuse of trauma language in general population these days. Like, it used to be clinical language, and now trauma, everybody thinks they're traumatized by everything. And so I really wanted to break that down a little bit at the very beginning here, because a lot of times what we're hearing, we hear words like trauma, traumatized, gaslit, PTSD being used as like, a general term, and that's just really not true. And so I wanted to dispel a little bit of that first just by talking about stress on the system. And so kind of looking at this visual, like, stress is not actually a bad thing for us. Like, we learn and grow from stress. So I'll use an analogy here of like exercise. When you go and lift weights, that is stress on your body, or you run or whatever, that's stress on your body. And it teaches the body how to respond to that. You get stronger from it. And stress in general, can do the same thing to us mentally and psychologically. So, as I've been reading and hearing things like about the anxious generation and all that kind of stuff, that newer book that's come out, we are seeing anxiety just being reported at all-time highs. And I think part of that may be an overswing to, understanding that stress impacts us and things like that, but overdoing it on how it's always got to be negative, because it doesn't have to always be negative. So we think about positive stress, which is just a normal response to something that's a bit, uncomfortable. So a first day of school or work, or like coming to do this talk. I've never given this particular talk before. I had some stress about it. I had some anxiety about it. That's completely normal. And, I'll grow and learn from that. My brain will adapt and all that sort of stuff. Tolerable stress, where it may be a little bit more than just, you're doing a new challenging thing, but, perhaps like the loss, grief and loss of somebody, or the loss of a job, or being maybe reprimanded at work, or getting a bad grade on an exam or a paper, something not going well, maybe a little bit of an interpersonal conflict. Yeah, it's stressful, it's not trauma, okay? Getting a bad grade on the exam. So my dear friend is a professor at Notre Dame, and he'll hear these students saying like, I'm so traumatized by that grade I got or whatever. That's not trauma, that is stress. And it generally is gonna be an activation of our body's response to something. You know, it might feel like anxiety or stress, but you know, you have some support, you talk it through, you go to bed for the night, your brain works on it, it's tolerable. And it may even, you know, take a while, and that's okay too. It may not be an immediate relief, and that's fine. And then we have more on the level of like toxic stress or more impactful stress, where you know, that kind of prolonged activation, things where it can move into trauma world, like chronic, you know, yelling in the home, or you know, witnessing things that are going on that are disturbing or violent or unsettling. You know, even something like perhaps like a car crash or a medical thing doesn't always have to be trauma, but it could be, you know, stress and kind of chronically stressful. So just kind of keeping in mind that stress and anxiety and discomfort doesn't necessarily mean trauma. So I really wanted to delineate that. And then we have, yeah, these kind of examples of distress and disturbing events, which do have the potential to become trauma experiences or have a traumatic response. So breakups and divorces, those are very unsettling, disturbing, distressing events for just about anybody. And yet they mostly do not lead to trauma or trauma response. You may feel as if, you know, it's overwhelming on a trauma level, and sometimes it can be, but that's, you know, that's kind of normal level. Legal problems, interpersonal conflicts, job losses, financial instability, medical issues. Now, medical traumas can be different. If you've had a major life-threatening illness or injury or something like that, very much potential for trauma. But then events or ongoing situations that maybe cause distress or fear or helplessness. Again, distressing and disturbing with the potential for trauma response. So, and of course, this is not an exhaustive list. We could go on and on with different areas where that is the, you know, the case. But when we really get into defining what trauma is, technically trauma, you know, you might say it's a trauma has happened, that's like an event, but usually when we say trauma, it's that psychological response to the event or to the series of events that is intensely distressing or disturbing, okay? And often when you have a kind of psychological trauma response, there's a sense of like helplessness or overwhelm, like it overwhelms my typical coping strategies. Perhaps a fear of safety or well-being, like I cannot be okay in the world. And then that added element of helplessness. So these are more common kinds of patterns we see when we start to see a trauma response. And usually, though not always, it's ongoing. So we'll talk about that and how that works here. So different types of trauma and how we kind of delineate those in the mental health field. We can have an acute trauma, something that happens that's disturbing, that might be like a single sudden event, like a car accident or an injury or something like that, that may have been life-threatening or perceived as life-threatening. And we have a traumatic response to it, that sense of I'm not safe in the world, helplessness, overwhelm. And when it's in that acute stage, usually they say around up to about a month. Some people say up to 3 months. There's not really a clear line on this, although the DSM says for about a month, we would call that acute stress disorder. So not quite PTSD yet. And then we have that chronic trauma response when there's been a repeated or prolonged, highly disturbing events. So that's where we would see maybe abuse, ongoing medical impact or illness or trauma, ongoing legal problems, ongoing bullying, you know, things of that nature, where there's this kind of chronic experience and then a chronic or longer term kind of response to it. And then probably many of you have heard this term complex trauma or complex PTSD. And it's a little bit like there are a lot of like books and experts that differentiate between complex trauma and developmental or attachment trauma now. And I think very often what I'm seeing, at least in my clinical practice, my specialty in my clinical practice is complex trauma, dissociation, things like that. we're often seeing that at the developmental level, meaning growing up, the brain is impacted by trauma, or from an attachment perspective with parents or caregivers. And then that results in like a complex PTSD response. But complex PTSD usually requires that it's a response to like multiple events, multiple traumatic events, and almost always interpersonal. So between people, between humans. Often during childhood, but you certainly can develop complex PTSD, you know, from beyond childhood when you're in an adult situation where you've been repeatedly hurt. So think like sex trafficking or some sort of ongoing interpersonal domestic violence or something. As an adult, you can certainly develop complex PTSD or complex trauma from that experience. And then that's where the delineation between developmental and attachment trauma, where developmental or attachment trauma really occurs early in childhood at significant developmental ages and milestones. So these are a lot of the clients that I see in my practice where they're coming in as adults, and their trauma experiences, and almost always ongoing, were happening when they were trying to develop their brain. And we know that the biggest period of brain development is 0 to 5, and there's other periods during teenage years that are highly intensely developmental as well, and other times in life. But those early years, kind of in the 0 to 5, and then onward up through, 17, 18, as the brain is still developing, and we know it's not fully developed until around 25. Critical kind of attachment periods and development periods where we would learn things like how to trust another person, how to get care, how to get our needs met. We would have this experience of like being reflected back by our parents and attuned to, and our needs met. And when they aren't, that can really impact the brain and the brain's development. And so sometimes we kind of shortcut by saying like, oh, it feels like they're stuck at the developmental age of, let's say, 5 or 15 or whatever it might be, because their brain is kind of operating, even though this might be a 40-year-old person sitting in front of us, their brain might be operating kind of from this place where they did not get the needs met for those parts of their brain to fully develop. And not that they can't, that's the cool thing. And that's what we're going to talk about, is that the brain has this ability to change and update. But initially it may feel that way. So we've got these kind of different versions of trauma, and there are other lists out there that will have additional things. But yeah.
We have a question online. They're asking, if you don't experience any trauma in childhood, can you still be diagnosed with complex PTSD, or would that just be labeled chronic?
Good question. So if you don't experience any trauma in childhood, would that still be labeled? Could you later on experience something and then be considered having complex PTSD, or is that just, what was the second part of that?
Or is that just labeled
Chronic. No, you absolutely could develop a complex PTSD response to adult things. So I think one of the examples I gave was like sex trafficking as an adult, or domestic violence in an adult relationship. When there's something that's chronic and ongoing, that's interpersonal and happening multiple times over and over and over, you can develop this kind of complex PTSD response to that, which I'll talk about a little bit more in a minute. So yeah.
That includes like professional first responder context.
Oh yeah,
like
perfect.
medical setting.
Perfect example. Yeah, first responders or people in medical settings where they're experiencing trauma after trauma after trauma every day, over and over. Yeah. So kind of defining PTSD according to the DSM, and let me define DSM, Diagnostic Statistical Manual, which is the diagnostic manual that we use as mental health clinicians to diagnose mental illness, essentially. And so PTSD is one of those diagnostic categories. So it is an actual medical diagnosis, at least, as defined in the DSM and the ICD and other kinds of diagnostic manuals. So in order to kind of qualify for PTSD, you have to have certain symptoms. So characterized, it says, by persistent symptoms, like you have to have a traumatic event that precipitates it. And that precipitating event usually would involve like an actual or threatened death, like life or death situation, very serious injury or sexual violence. And so here are those symptoms that usually you have to meet several of them to meet full criteria for PTSD. Not that anybody wants this in their life, but it's you know, kind of a checklist. So this would be folks who have intrusive memories or intrusive thoughts about the event that happened. So they would just be going about their normal kind of day-to-day life and constantly having things, what we might call flashbacks, intrusive thoughts, intrusive images, memories that are unwanted and you know, not kind of produced, not desired. They kind of come in unwillingly. Nightmares are very, very common in PTSD, and sleep disturbance in general is common in PTSD, but nightmares in particular. One of the other categories that defines PTSD is avoidance. And so people who have a post-traumatic stress disorder reaction are avoiding anything that reminds them of the trauma or trying to avoid it. Negative cognitions and moods, so just to say a moment about that, it might look like anxiety, depression, but negative thoughts. Maybe negative thoughts about themselves, like I'm bad or I'm broken or I can't heal, or about others, other people can't be trusted, the world is not safe, those kinds of things. But the trauma event and the response to it has changed kind of their outlook on themselves or others. And then changes in kind of arousal and reactivity. So you hear, you know, you think of kind of commonly, you know, loud noises being startled. So we call that the exaggerated startle response, where a loud noise, you know, maybe 30 of us in the room would be like, oh, what's that? And then we could regulate pretty quickly. Somebody with PTSD may become so dysregulated by a loud noise and have a very hard time re-regulating, you know, kind of regulating after that. So their arousal is higher, they're more easy to, you know, kind of feel anxious and are usually hyper vigilant to the world around them. So really looking all the time for danger, either through sounds or sights or, you know, different kinds of things, but kind of scanning all the time on a hyper vigilant level. So that's what we're looking for in PTSD diagnosis. And then to the question there online, a little bit more on complex trauma, complex PTSD. It's usually developmental, early and ongoing, but not always. And that very often it's from caregivers or adults. But the more important thing would be that it's a repeated multiple events and it is interpersonal usually with other people. And what the kind of over the edge thing that happens in complex PTSD, you have all these same symptoms that you would see in PTSD. But then what you have is this kind of deeper level changes in beliefs about myself, about others, usually a real lack of emotional regulation or ability to regulate emotion. So, you know, folks who once they get upset, it's very, very hard for them to calm down and reset and come back down to kind of a baseline or homeostasis, and they stay in kind of hyper arousal a lot, or hypoarousal, which I'll talk about in a little bit, which is like a shut down, numb state. This is where we often, but not always, will see personality disorder issues. So folks that, you know, in the past, or can still be diagnosed with things like borderline disorder or, you know, narcissism and things like that, where you see these traits of kind of characterological personality changes that would not have been there without the trauma. And so I want to just say a note about that because it's important, I think, in mental health crowds. You know, like borderline has a really bad name. Like we hear borderline personality disorder, we think, oh God, I don't want to work with that client, or that's going to be really hard. And that's like folks that we see who are like self-harming very often, they have a very difficult time regulating, and have a really tough time in relationships, where it's kind of this like, get away from me, no wait, come back to me, no get away from me again, no come back to me. And it's like this constant struggle in most relationships, usually highly reactive, explosive, suicidal ideation. Those are a lot of elements of like borderline personality disorder. The way that I look at that, and a lot of people look at that, is through a trauma lens. Because most, not all, but most people who have a diagnosis like that have experienced usually chronic trauma that has developed into complex PTSD with a level of dissociation that I'll talk about here too. So that consistent relationship or relational issue and reactivity can look like, oh, that person's just crazy or being borderline. I'm putting that in quotes. I'm not saying that, just so everybody's clear. But very, very often can come from a trauma response. So just kind of keeping that in mind. And then the other element with complex PTSD is a layer of dissociation. And so just to define dissociation for a moment, dissociation at its core, at its root, the best word to describe that would be disconnection. So when you hear the word dissociation, it's like disconnection. And disconnection could be from like myself, like a sense of I don't want to think about myself, know myself, I want to cloud myself away, not even want to, but kind of as a coping strategy, as a survival strategy, or disconnection from others very often, disconnection from the world, disconnection sometimes from like reality in a way, or perception of reality. So think of dissociation as disconnection. And the way we see it show up clinically in our office is folks who say things like, I don't have memories, I can't remember things, I feel like I'm in a fog all the time. Or they seem spacey a lot, like they're often sort of, can't remember, can't hear what you're saying, feel like they're far away, feel like they're in a tunnel, and describe themselves as feeling spacey, fogged out, that kind of thing. Different than, say, like ADHD and neurodivergence that might show up similarly sometimes. Dissociation is almost always a result of trauma, and in particular, complex trauma. Is that all making sense so far? Any questions about that? Okay, all right, so that's the kind of easier stuff of just like defining what we're talking about, stress, trauma, PTSD, more chronic or complex PTSD. We kind of have a spectrum. And everything I talk about, it's always on a spectrum. So very, very rarely is it gonna be all or nothing. So now we're gonna get into a little bit of brain stuff. And we're following so far, we're going along, okay, good. All right, so one of my favorite humans in the world who teaches about neuroscience and all things related to neuroscience is Dr. Dan Siegel, who is a neuroscientist, and he's written dozens of books about neuroscience and therapy and trauma and children and adults and parenting and all kinds of things. So he wrote a great book called Mindsight, Parenting from the Inside Out, for those of you who are interested in parenting and trauma and things like that. But he has a ton of YouTube videos out there. If you ever want to Google Dan Siegel, his name's right there. I could listen to this guy talk forever. He's just one of those people that can take really complex topics and boil them down into really user-friendly language. If you ever hear him on a podcast or anything, highly recommend. But he has this beautiful thing that we call the hand model of the brain. And so you can all do this with me right now. You don't have to, but sometimes it can be helpful to just have that felt sense of it. So if you take your hand and tuck your thumb into your hand, and then fold your fingers over your thumb, this is Dan Siegel's hand model of the brain. So this would be your brain tucked in just like this, okay, into your brain, and just kind of, or into your head, and just to kind of name what he's doing here with that. Here we have like the brain stem going down into the spinal cord, okay? Brain stem here, we all have one, we wouldn't be alive without it. And it regulates things like breathing, digestion, and all these things that we don't think about most of the time that just kind of keep us alive as living physical beings, okay? And then up, so that's like the earliest thing to develop when we're in utero, and every living system, just about every living system in the world has some version of this that kind of handles their breathing and regulation. So that's common to living things. But then we move up into here, our thumb is our limbic system. And this is our emotional center of our brain, generally speaking. And it handles things like emotion regulation, reactivity, motivation, things of that nature that kind of get us excited, kind of our excited responses and our sad responses and all the things kind of in between here. That's our limbic system, or what we'd call subcortical brain. He sometimes will call this the downstairs brain, just to be super easy. And then what folds over the top, this is very unique to us as humans. This is our prefrontal cortex, or our cortex, cortical area, but prefrontal cortex in particular. So you'll see here, because I'm going to be talking about these areas of the brain, you'll see here, we've got the spinal cord brainstem, and then in the middle, the limbic system, which is going to hold things like the amygdala and the hippocampus. Small structures in the brain that do a lot of memory processing, emotional processing, which are related to trauma. And then those fingers that come over the prefrontal cortex, which we'll also talk about in trauma. So whenever I'm talking to people about brain stuff, my clients or somebody I'm trying to, if I'm working with medical staff in a hospital, I'm going to show them the hand model of the brain. And one of the things that Dan Siegel talks about is that as humans, we have this beautiful thing called a prefrontal cortex, which helps us plan and think and, think about consequences and what happens in the future and make lists and learn and all these kinds of things. Like all of you are using your prefrontal cortex right now, just listening to this. But sometimes when things impact us, not necessarily just trauma, but sometimes definitely trauma, but sometimes things less than trauma, we can do what he calls flipping our lid. Okay, we flip our lid and our prefrontal cortex, our thinking brain that plans and understands perspective goes offline, kind of stops working as well. And we're totally activated in our limbic brain. And that means we're highly emotional, whether that be hyped up, anxious, activated, or shut down because we're trying to avoid, something scary or whatever. But that's when our prefrontal cortex kind of goes offline. So you all have experienced this. If you're a human being, you've experienced this on some level where you just are not, you might say, I'm not in my right mind. That would be prefrontal cortex is kind of offline and you're fully in limbic. So sometimes when I'm teaching that, I'll say, okay, we've gone limbic. So how do we get this prefrontal cortex to come back in using our thinking brain? And we'll talk a little bit more about that. But we need a balance. We don't want all thinking brain. Some people like to live there, and that's a lot safer. But then if we don't have anything, not that we never have anything, but if we're constantly shutting down our limbic brain, that's not kind of healthy, balanced living either. So when we start to think about how trauma impacts our brain, we're going to look at these kinds of main areas of the brain where trauma has an impact. And the number one thing that you've probably heard of is the amygdala. And the amygdala, if you've ever heard of Bessel van der Kolk, he wrote the book, The Body Keeps the Score, one of my all-time favorite books. So if you're interested in trauma and the neuroscience of trauma, I think it's very readable. I've heard other people don't think so, but lots of people have read it like in the lay population, not just clinical population. It's a very popular book, but The Body Keeps the Score by Bessel van der Kolk will talk about the amygdala as the smoke alarm or the fire alarm of the brain. It's the place where things happen out here and we bring it all in through our sensory information, like our sight and sound and smell and taste. And the brain will filter everything that happens to us pretty much through centers that will send information to the amygdala. And the amygdala is determining in milliseconds whether we're in danger or not, almost all the time. And if it senses any threat or danger, it will send up the fire alarm, the smoke alarm. And that's really helpful in the world if we're about to see someone run a stop sign and hit us or something like that, or if something very loud happens, it determines quickly whether we need to fight or flee or freeze or how we need to kind of handle that quickly with some other brain structures. But it's this tiny little almond shape. Technically there's two of them, but and they're in the center of the brain, center of the limbic system, that will activate when there's any sense of threat. And we need those. That's our threat detector. So unfortunately, what happens in trauma, when somebody has experienced trauma, whether it's one or two times or lots of times, is that amygdala gets overactivated. It starts to get hypersensitized and it thinks everything is danger and threat, or a lot more things than should be. So that can get really hyperactivated. We'll talk more about that in a minute. The other important part of the brain when you're thinking about trauma is the hippocampus. And the hippocampus, it's actually like a seahorse-shaped place in the limbic. Hippocampus actually translates from Greek as like seahorse, basically. But the important thing about that is that it is one of our key centers for memory processing. And when we're talking about trauma, we're almost always talking about memory, because it's the way the brain handles things that have happened to us and what it thinks might happen to us in the future. Okay, so in the hippocampus, we actually see what they call hippocampal volume, or the size of the hippocampus can be shrunk and smaller in chronic trauma survivors. And therapy, it's certain types of therapy and sometimes medications and things like that can actually help grow hippocampal volume. So it has more ability to handle things that happen after you've done work on that trauma that kind of shrunk it initially. But what happens when we have trauma on a basic level, and I go into this more, is that that can impact our recall, our memory, how we remember things and how we react to memories of things. So that hippocampus is important. And then the prefrontal cortex, that's our emotional regulator, more of our thinking brain. And when we don't have trauma, we can kind of balance. We go back and forth between some emotional reactivity, and then we can think it through, and we can plan, and we can understand the consequences of our actions. We can think ahead, all of those kinds of things. But when we have trauma, especially repeated trauma, we have less access and connectivity between our prefrontal cortex and our limbic areas. So things like that you might see, and especially those of you who work with children, when there's been a lot of trauma, things like not considering consequences, so doing things impulsively, things that seem like, why, you might say like, what were you thinking? Well, they weren't thinking, they were reacting limbically, because that prefrontal cortex has less kind of control in a highly traumatized brain. And then this is technically the whole body system, the autonomic nervous system, or ANS, we'll talk more about that. But this is that nervous system that's brain-body connected through the vagal nerve in the brain. And when we have trauma, there's chronic dysregulation of that. And a lot of that has to do to your initial question about neurotransmitters and hormones and how they're regulated in the body. Higher cortisol responses, higher adrenaline responses, lower access to dopamine, serotonin, things like that, which, okay, I'll get to that in a minute, I'm getting ahead of myself. But autonomic nervous system dysregulation is common in trauma survivors. And then we have this thing that's actually maybe not in general world, but in trauma world, this area of the brain is kind of like all the rage these days. So I wanted to include it. It's a little bit of a hard concept to understand, but it's called the default mode network in the brain, or the DMN. And this is actually a cluster, like a region in the brain, I'll show you a visual in a minute, that handles our brain when we're at rest or in idle mode, kind of, and has to do with like thoughts about self and like self in the world, as well as past and future, and regulating that. And folks who've been traumatized, what they've kind of found is through the impact on the default mode network, that trauma survivors tend to feel more stuck in the past, that it's very difficult for them to believe that it's okay now, even if it really, really is, and all evidence points to I'm perfectly safe. Their brain, partially due to their default mode network, will feel like it can't be okay, like a little bit stuck in the past, difficulty relaxing. So I know I said it's one of my pet peeves that you go on TikTok and people are always diagnosing themselves based on TikToks or whatever. And it is one of my pet peeves. But I've noticed that I'll see this on various social media where it's like, this is not normal. This is a trauma response. Like your inability to relax is a trauma response. Not always, but yes, that can be a trauma response. Okay. So kind of looking at this with more of a brain visual here. I mentioned the amygdala deep in the limbic system, the hippocampus similar. So again, limbic. And then this default mode network is kind of connectivity in regions, again, more in the limbic system, but also connectivity to the prefrontal cortex as well. So, but mostly when we're talking about trauma, we're talking about where it impacts kind of deeper in the brain and the connectivity there. So how does that impact kind of what's happening in our brain and what's supposed to be happening? Again, the default mode network is like that self-referential kind of processing, like who I am, what I believe about myself, am I okay? Am I a good enough person? Am I broken? Am I damaged? But also like how much I have to do in the world to be okay. That's kind of another way of looking at it, and where I am in time-space continuum, which can often feel very stuck in the past. Memory storage, that's that hippocampus. So people who, I'm not going to say clients because you're not all working with clients, but people who've experienced trauma will often have memory issues. And they'll say they can't remember things as well, or their memory feels off, or they feel really stuck in certain memories. And then that dissociation where they disconnect them and, you know, avoid or numb from various aspects of things they've experienced. And then they have this chronic stress response in the body through hormonal and neurotransmitter kinds of neurochemical changes, I should say. So if you like tested a person who is a trauma survivor and experiences PTSD or complex PTSD, their hormone levels are going to look different. They're going to test differently. Generally, they're going to have a higher cortisol response, except it's really weird in it's not weird, it's something that happens when you have extreme chronic trauma early on. Actually, the body can learn it wants to shut itself down to survive, basically, and you'll find low cortisol in some clients like that, which sounds counterintuitive, but their blood work will literally look different. They'll have a different, you know, cortisol level, dopamine levels, serotonin levels. And something I want to say about that is we think of dopamine and serotonin as only in the brain and impacting the brain, but actually serotonin is far more found in the gut, or what Dan Siegel would call the gut brain. So something like, well, there's a debate, but somewhere between 70 to 90% of our serotonin in our body is actually found in or around our gut, or our gut brain. And then he says we also have a heart brain. We have an entire kind of system of neural connection around our heart, and then of course our brain. And so these are areas where, if you can think about all these chemicals that are going on, hormones and chemicals going on through our bodies, it's not just impacting our brain, our hearts, our digestion. We see digestion issues a lot with trauma survivors. And of course, heartache and things like that. So that's all impacted there. So I want to go through each of those that we just talked about over here a few minutes ago, how trauma kind of affects the brain and body. I want to go through each of those kind of individually for a moment. Even it might be a little bit of repeat, but the first thing I want to mention is that hyperactivation of the amygdala, which is our fear center or our fire station in our brain. So it's sounding the alarm. So normally it would just be detecting threat. So for instance, if all of a sudden we're all sitting here, we're just, you know, talking, listening, whatever, if all of a sudden we heard a loud bang in that room over there, most of our systems would be able to go and attune to it. We would definitely orient toward it if we could hear it, and orient toward it, and we'd have this kind of like, what was that response? And then as soon as we realize, oh, you know, somebody slammed a door over there, somebody dropped a giant box or something like that, we would all go, oh, okay. And we would just kind of re-regulate pretty quickly. Somebody who's experienced a lot of trauma, they will stay in that heightened state for longer. And that will impact all those neurochemicals that are going on in their body, that will shoot those up and around. It's harder on the heart, it's harder on the gut, it's harder on the brain. They have a harder time concentrating, remembering, operating, you know. So thinking about those of you who work with kids, whether it's in a school or a hospital or something like that, they are going to have a harder time concentrating, learning, sitting still, all of that, because their brains are kind of on threat detection. And of course that goes for adults too. So this leads to like an exaggerated fear response, you know, where people will be startled really easily and then can't kind of readjust. I remember when I used to do presentations at the Center for the Homeless, back when I was still working, I think when I was still working here at Madison Center actually, and somewhat after that. And I would go in and talk about real basic like trauma 101 to some of the guests that were living there. And I would ask them, when you came into this room, what did you do to like detect or keep yourself safe? And, you know, who could share that with me, you know, and they would raise their hands and they would say these things like, well, I had to see the window, I had to see the door, my back can't be to the door, I have to look at this, I have to be beside this person, I have to know where I am, I have to be quick to exit, you know, all these kinds of things that were things that most of us do not think about on a regular basis, but for them it's just day-to-day life. So it's this hypervigilance. And then that difficulty distinguishing it's a real actual threat that's coming at me, or, you know, okay, I can re-regulate after that, okay? So the hard thing is what you want to do often with people who are in that state, those of us who aren't in that state, we want to logic them through it. We want to say like, it's okay, look, like we're just at Oakland, it's just a room, like no big deal, like somebody dropped a box, it's not a big deal. And that is actually the opposite of helpful because their thinking logical brain can't compute that. I mean, you can do it, it's not gonna hurt really, but it is gonna diminish a bit of what their internal experience is. So a little bit better would be something like, yeah, that was scary, huh? Like, oh yeah, that kind of got me too. And let's take a moment to just see what we need to do to kind of regulate our bodies. I'm gonna get to that in a little bit. Okay, so that's the amygdala. Yeah. Lily.
We have a question online.
Yeah.
Do you have any insight to some of the folks who have occupational trauma, so fire, police, ICU, who seem to have a down-regulated startle response?
Yes.
Like nothing seems to startle them even when it should.
Right, yeah. So that's the opposite. So just to repeat that question for anybody who couldn't hear, our folks who are in like ICUs, firefighting, police, you know, military, things like that, that have more of a down-regulating, where they aren't easily startled and maybe should be, that kind of thing. So that comes from a lot of training and a lot of trauma. So they tend to go more toward, and I'm not an expert on this area at all, I don't work with first responders very often, but they tend to go, instead of hyper vigilant, they tend to go hypo vigilant or hypo aroused, which is like a shutdown. And so these might be the folks that if you took their blood, they might actually have low cortisol rather than high cortisol because their systems have learned to overcome kind of our natural state of response to threat and hyper aroused state, kind of like a hack there to like shut down more of those neurotransmitters and amygdala response. So yeah, it's a dampening and it is a learned experience. It's not, generally speaking, part of the normal kind of population. You see this where people who have brain injuries to the amygdala, you'll see that same thing, more of a downregulate. I'm not worried about anything, I have no fear. And in the first responder population, though, it's not that they have no fear, they've learned to train themselves out of it through years and years and years of experience. But if anybody in the room wants to add anything to that, I'm open to that, yeah.
I was going to say, isn't that kind of what we do too?
Yes, as therapists.
Yeah.
Yes.
I was thinking back when I was in internship, and one of my clients was a parent was schizophrenic. And when you think about it as therapists, and this is something that's not talked about a lot, most like first responders,
Yes.
we're often in very dangerous situations.
Yeah, we can be considered first responders sometimes, yeah.
Exactly.
Yeah.
Even BSI's also in the past, it's also work with addictions. We've been in situations
Yes.
where it was extremely dangerous. It would be that when we've experienced it, it was very dangerous. But we trained ourselves as therapists to just feel let's calm down. We
Yeah.
understand mode. But the thing about it, and I noticed that we do it so much that I catch myself even doing it beyond
Oh yeah.
therapy. But I have to
Yeah.
know, you need to feel
Yes.
this is not the time for you to be
Yeah.
in therapy mode.
Yeah.
But it happens to us because we don't talk about it though. And I
You're
wonder
right.
why. It's a lot of times acceptable for first responders to do it, but as a therapist, it's almost like expected. You should know what to do with trauma.
Right.
You should know when you got this person
Yes.
with social identity disorder in your office and they switch personalities and you're sitting there and you would have told me different person.
Yeah.
Like,
We're not trained in that.
Spanish right now.
Yeah, right.
So
Yes.
it's like,
Been there. Yes. I totally want to highlight this comment here, and the comment for the online folks is that we as therapists do this as well, or those of us who are in a mental health, kind of context, we do this also, and sometimes we are first responders, but we have learned to depress or dampen kind of our trauma response, and that's why I make a little joke about it, but it's not funny actually. Many of us who are in the trauma field come from traumatic backgrounds ourselves and have learned to overcome that through a version of basically dissociation. And, we can call it containment if you want to be on the healthy side of things, that we are really good at containing. Compartmentalizing.
You do a lot of therapy saying.
Exactly. Like, or is it dissociation? Or is it trauma? Yeah, right.
Yes.
Yeah, it's a great topic to kind of delve more into sometime. I agree, but yes, we do the same thing. And then we see it, and the problem becomes, and we see this with our first responder populations, therapist populations too, as we go out back to our regular life, our humans that we live with and people that we interact with, and we don't have the same kind of reactions that other people might. And people feel like, what's wrong with you? Like, you know, there's a little bit of a disconnection there. So I really appreciate that comment. Yeah. So second kind of area, I mentioned the prefrontal cortex several times. That's the rational thinking, the planning. Trauma weakens the prefrontal cortex and reduces our access to it. And the prefrontal cortex does a lot of things, but it's often what we call our executive functioning. And for those of you who work a lot with neurodivergence, ADHD, you're probably hearing a lot of things that are like, wait, that sounds like my ADHD kids, or sounds like myself with ADHD, or whatever it might be. Yes, and there's a lot of debate about this, you know, is that traumagenesis ADHD, is it, you know, neurological ADHD, you know, all that kind of thing. There's a whole debate I'm not going to get into about that. But yes, ADHD and bipolar disorder and other things can really look like trauma too. And sometimes it can take a while to differentiate that diagnosis, but they're also often very overlapped and interlinked. So weakening the trauma, weakening the prefrontal cortex and reducing access to it, that is regulating of emotions and executive functioning. So things like planning, looking at clocks and calendars, being on time, knowing that there's consequences to our actions, impulse control, and then the ability to kind of feel an emotion and then balance it with thought and perspective and place in time space continuum. You know, when we have less access to our prefrontal cortex, our thinking brain, our planning brain, it's harder for us to do that. So people can sometimes get very frustrated with, you know, people in their lives who experience things that, you know, they have trouble tracking things like time and when things are due and when I'm supposed to show up and how that, you know, when I get there, and how to focus and how to listen and, you know, all those kinds of things, which could be a result of trauma there. So decision making is another piece. So you might see someone kind of get into stress and then be unable to do things that might look or seem very basic to you, like, oh, I need to be at this, you know, class at 10 a.m. and now it's 10:30 and I totally forgot where I was supposed to be and that kind of thing. So that can happen. And then the hippocampus, again, deep in the limbic system. As I mentioned, you can actually see on brain scans shrinkage. Trauma survivors, people who experience trauma, especially over time, their hippocampus can actually be physically smaller and can grow as a result of therapy and things like that. So this will cause things like, I can't remember, or I can't remember the whole thing, have fragmented memories. Flashbacks are really common when the hippocampus is affected. Difficulty kind of putting things in context, knowing that, you know, this is the past, this is the present, and, you know, kind of like spatial consideration, like how far away something is, that can be helpful or can be impacted too. But again, that's something where you can't logic them out of it. You can't say, well, look here, we're fine now most of the time. You want to invite their brains to see that. It's not that that's not useful at all. And to say, you know, where are you now? What do you see around you? We're going to talk about that. That can be helpful, but it's trying to convince them and push them to know that is not always going to be useful. Yes, Maria.
Is the sort of expectation of like
Other memories too.
Like, yeah, like if you take the trauma as kind of a defining event going forward from
Yeah.
the trauma and ability to sort of remember and
Yes. Yeah, so the question there is, with the fragmented memories, does that only impact sort of from trauma time on forward, and is it only the trauma memories, or is it general memories as well that can feel fragmented and difficult to kind of place in time and space? It tends to be, yeah, the latter, like more, not just the trauma memories are fragmented, but memory in general, and the ability to put a memory in context and timelines overall becomes impacted, because the hippocampus does that as part of its role. Yeah, so for those, you know, for folks who have like very linear brains, very time-oriented brains, who can say, you know, this happened, no, that was in December, this was in February, well, that would be pretty hard for somebody who'd had a lot of trauma and their hippocampus is impacted. Yeah.
I have a problem with individuals with intellectual disabilities.
Yes.
And they're already struggling in a lot of those areas.
Right.
So I'm wondering how trauma might affect them differently.
Yeah, it's a good question. So the question there is working with people with intellectual disabilities who are already struggling in those areas. And then how does trauma impact that population in general? I will say, not my area of expertise, and also there's not enough research on this. I think this is a population that gets left behind, which is unfortunate because they're much more likely to be traumatized. So their incident of trauma in the community of disabled individuals in general is higher. And so the impact and how to study that impact, I think, really needs to be improved. But definitely it's going to lead to further reduction of access to things like prefrontal cortex and memory consolidation and things like that. So it's going to impact them really similarly, I think, in those ways. Something else I was going to say about that. I lost it somewhere in the middle there. But yeah, I think there's a lot more we don't know about that and how that can, I think what it may also look like is more on a somatic level. When I've worked with people who've had more cognitive or intellectual disabilities and then consulted with people like that, what you see is more of a somaticization of symptomology. So they may not have the words for it, or the language, or be able to describe exactly what's going on or have that kind of thing, but they may have more like physical ailments, it may show up more physically in populations like that too.
On that note about kind of the somatic responses that may be kind of linked to trauma and PTSD, I've read, I think in the past that, and even I think in the most recent DSM, there are some kind of considerations about cultural differences in how people maybe report trauma.
That's right.
I wonder if, like, in your practice at all, if you've like noticed anything about that, or if you have any like guidance around that.
Yeah, good question. So I'm going to summarize that for the online folks as basically an understanding that somatization, or the somatic response to trauma, being maybe looking a little different across different cultural populations, and how that shows up and kind of, is that a good summary of your question? Yeah. Yeah, so I've also heard that and read that and seen that in lots of the literature. And I love somatic work. I'm actually going to be talking about somatic therapy here in a little bit and accessing things that way, because technically a lot of people who are traumatized will lose more access to their, upper brain functions, and then the body will kind of keep the score, as Bessel van der Kolk says. But what we are seeing a lot of, and I will admit that I haven't kept up perfectly on this research or literature, but that people from different cultural backgrounds, the somatization, so how it shows up physically in the body, is the way it's represented. And partially that can be because they have to have this kind of, in a lot of cultural, contexts, especially where they're continuing to experience discrimination, racism, things like that. It's kind of like, I have to stay looking as strong as possible here mentally, but my body is an acceptable kind of like response. Like if I go and I have a stomach ache and a problem that's physical, I can get the care and attention I need, although we know that there's lots of discrimination in the medical field around that too. And this is a very simplified version of this. It's much more complex, where there's sort of this higher standard of like mental toughness because of the ongoing discrimination of things that they have to experience, and inability to kind of have the support system of being able to talk about what's happening mentally or psychologically, and that not being acceptable culturally, but physically we can go and that can be represented and show up. So that's a little bit of that work there. But yeah, we do see that it shows up more that way across cultural landscapes and also various disability kind of populations. So yeah. Okay, so going back to the default mode network again. Again, this is that idle mode of the brain. So we think daydreaming, fantasizing, rest, not focused on a task, when we're not focused on a task. This can be very hard. I see this a lot with trauma survivors, where that mode, and I didn't know there was a word for it until like the last 10 years, that kind of mode can be really difficult for folks who've experienced a lot of stress and trauma. So they'll find that when they have downtime, there's a lot of rumination, checking out, dissociating, or wanting to dissociate more with things like, overeating, overusing substances, zoning out on a phone, kind of that kind of thing, which helps them kind of go into an idle mode more easily than those of us, those folks in the world who haven't experienced a lot of trauma can kind of go into idle mode and live there and be okay, which our brains are supposed to do. But when you've had a lot of trauma, that's feels like a very dangerous place. It may not be dangerous anymore, but it feels that way, and might use more substances or activities to kind of feel downtime or feel idle. And so, and this can also kind of then run into, it's kind of hard to describe how the default mode network impacts kind of the self-referential, but what we see is a higher level of self-criticism in trauma survivors. There's something wrong with me, I'm broken, I'm bad, I'm worthless, I'm unlovable, those kinds of things. Kind of stronger inner critic voice and stronger feelings of worthlessness, which makes sense when you think about, how much they've been hurt in situations like that. I'm gonna do one more slide, then we're gonna take a break. And then we have that overactive stress response and the effects on the autonomic nervous system. So this is that chemical stuff that happens in the brain with the brain-body system. Sometimes they'll call this the hypothalamic pituitary adrenal axis, HPA axis, which goes into overdrive, which leads to this chronic cortisol release in the body. The HPA axis being hyperactivated, chronic cortisol, where the person kind of constantly feels like, I'm ready for whatever might happen. Well, when we feel that way, and when we're in that state of being, we feel more anxious, we would report more anxiety, we can't sleep. Sleep is very effective and really hard to return to a baseline of calm, okay? So I've talked lots of sleep disorders, fatigue, chronically kind of tired. We'll see that a lot with trauma survivors. So gathering back up here. Thanks for your interest and engagement and excitement about the topic. Like I said, I could go on and on about it, but I've got 50 more minutes to go on and on about it. And actually, this is probably the part I like even more is, what helps with this situation, because, we talk about all these things that happen and all these things that are impacted and how negative that is and how hard that is, but we actually can help, and that's the best part for me. We can help ourselves, we can help our clients and other people in the world. So that's the exciting part. So the first thing I want to kind of introduce, and I know some of you probably are very aware of this concept, it's another concept coined by Dan Siegel, called the window of tolerance. I just don't think you could ever talk about this too much, especially if you have clients or people that you're working with who are impacted by trauma. As you go into moving into like how to help people with trauma that they've experienced and their traumatic responses, I introduce the concept of window of tolerance to every person that I work with. And so I will often use it as an analogy to the pain scale that you'll see in hospitals and medical clinics, where they have a sad face for like a level 10 of pain and like a happy face for level 0 pain. Well, let me tell you that I was at Beacon last week with a kidney stone, and that pain scale does not cover it. Like a 3 is like, I'm smiling. I'm like, okay, I feel less pain after they gave me some morphine and stuff. And I feel less pain, but I'm definitely not smiling about it. So I was really studying that pain scale just last week. But anyway, so this concept of window of tolerance, we all have a different window of tolerance based on what we've experienced. And so, kind of general population, not traumatized, not working in first responder kinds of situations, that kind of thing, we might have a window of tolerance that's still going to vary based on our kind of biology and our makeup and all that sort of stuff. But the idea here is, how much stress can we tolerate before we start going into maladaptive or tough coping strategies to deal with that thing? And it's not a judgment thing. So I want to be careful that we're not judging, oh, that person has a small window of tolerance, they're weak, or this one has a really large one, they're strong. And we sometimes will say, well, I have a really high pain tolerance, like that makes us some sort of like super strong person. Not necessarily. It could be that your system has learned to dampen and depress, outside stimuli in a way that actually is hurting your system more internally. So I just want to name that. So window of tolerance, but what we're looking for is who we're working with in the room, clients, whatever it might be, and how much they can tolerate of our intervention, especially when we're dealing with trauma response. So in our general ideal window of tolerance, that's the green zone there, optimal state, we can access both like thinking brain and emotional brain. We can do both. So we have, in the EMDR world, we call that dual attention or dual awareness, where we have kind of like one foot in the present and I'm here with you, but I can also have one foot at the same time in a difficult memory or remembering something awful that's happened to me without getting totally sucked into that or without being totally here and shut down from it. Okay, so that's that optimal place. But when we get outside of that window of tolerance because of things that are happening or have happened to us and the way we've learned to respond, we can sometimes go into that hyper arousal state where we cannot calm down. And this looks like, it looks like anxiety. Sometimes it looks like panic. Sometimes it looks like terror, fear response, hypervigilance, hyper aware, overly alert, kind of up here. And then sometimes we will go through that. Well, we often go through that. And then some people will default really quickly down to hypoarousal. And that's going to look like more, not depression like the mood disorder, but like a depressed state, shut down, numb, disconnected, unmotivated, spaced out, non-feeling, okay? And there are different levels of extremity of this, of course. But when we start to see either of those things in our clients, as we're talking about trauma or trying to help them with something, we know we've probably gotten out of that window of tolerance. And we want to help to kind of bring them back into that green zone here. And I'm going to look at this in a variety of ways here. But keep that in mind that, okay, so those of you who work like in hospitals or legal systems or things like that, when you're trying to get a story from a patient or a client or a person you're working with, and they're getting overwhelmed into hyperactivation, they're out of their window of tolerance. So you might bring it back down to, hey, tell me about your dog, or tell me, what do you see around this room? So I'm getting ahead of myself, but that's the idea there. And I want to introduce here, with some of you, this will not be new, the concept of the polyvagal theory. And this is kind of an approach to the world. It's not necessarily just therapy, although therapists talk about it all the time in therapeutic contexts and things like that now. But the polyvagal model or polyvagal theory was developed by Dr. Stephen Porges, and he and his son have really have done huge amounts of research and teaching and writing about this concept that our autonomic nervous system adapts to safety and danger and life threat through kind of three states of being that runs, I'm going to show you a visual here for a minute, that runs through this vagus nerve that goes brain all the way down through the systems of the body. Remember, I've already talked about how important the gut brain is, the heart brain, but also you see lungs and all the organs and everything, and up into the brain center. So this vagus nerve is kind of central to this concept here. And the Porgeses will talk about how the vagal nerve can, and the different ways that it's impacted, can respond in a few different ways. So when we're in ventral vagal, I'm going to go back to this visual now. When we're in ventral vagal, that's that green window of tolerance where we can connect with other people and we feel safe and open, maybe curious, compassionate, calm, those kinds of things. When we have threat or perceived threat, we go into a sympathetic nervous state, which is that fight or flight. Okay, that's our system saying something's wrong here and we need to do something about it. And we go into that flee, run away, or fight, kind of go toward in a sort of aggressive way. And then as we go through that, then when we get to more extreme levels of trauma, especially for folks who are in trauma that was inescapable. And I want to highlight that word inescapable. These are the ones you're going to see with the most complex trauma responses. When they were chronically hurt, and as children, it's almost always inescapable, like if they're being hurt as children because they don't have any power or control. Then we start to see more of that dorsal vagal or that shutdown response, which sometimes people will call it's more than the freeze response, actually the collapse response. It's like a play dead. And so this, I'll talk more about that in a minute. So the key here is that we all can go through those states based on what happens to us. But when we have trauma, especially chronic trauma, it disrupts our ability to regulate that. So we are automatically going into hyper aroused and we can't bring ourselves down, or we're automatically going into shutdown numbing and we have a hard time pulling ourselves back up. So it's like a lot more work. We're stuck in these survival responses rather than being able to see, oh, I'm safe right now. I can connect right now. It's like an automatic hijack of the system. Like as if somebody has just hacked in and is like pushing buttons and everything feels overwhelming and it's harder to do. So again, that's that visual of the vagus nerve. It's the essentially your body brain's master control switch as to how we respond to input coming in, okay? So sometimes we'll use this analogy of the traffic light with the polyvagal system, and I know the other one had blue on it, but I like this one better. When we're in green zone, so you can think about this as feeling states. When we're in green zone, it's like a go. We've got this. I'm safe. I can talk clearly. I can connect with people. I can feel open, calm, curious, things like that. When we're in yellow zone, this would be that sympathetic fight or flight. We all have this response, but we can kind of come through it. We can say, oh, wait, that's dangerous. I'm going to respond to it. And now, okay, that's over. And I can come back to ventral. And then red is that real dorsal, what we call shutdown, immobile. So sometimes in the somatic therapy world, they'll talk about this as the play dead concept. So like out in the natural world, if you have like a gazelle running across a field and then you see a lion come and capture that gazelle and take it down, sometimes the animal's autonomic nervous system will play dead as a means of escape. Because every once in a while, if you play dead, the predator loosens its grip just enough that you can get out of there. And so this is not something we think through. And I tell my trauma clients this all the time. Your response when you were attacked or hurt or abused or whatever it was that happened to you was not something you thought through or even could have thought through, because your brain's prefrontal cortex went offline to conserve energy and go straight into limbic activation in order to respond in a way that will keep you alive. And that response may not make sense to you. So I work a lot with sexual abuse and sexual assault, and people will say, I wish I'd screamed louder, I wish I'd kicked, I wish I'd, punched, I wish I'd fought. And I'll say, your brain automatically decided without your thought process or consent how to get out of that situation without getting hurt more. And that may have been shut down. And actually in lots of sexual assault encounters, that is the safest way to get through it. Because the more you fight, the more hurt you get sometimes. I'm not saying always. Trying to get away doesn't work, those kinds of things. So I'll normalize that for people. So red is that dorsal or immobile shutdown. These are normal states that just get hyper, overactivated and harder to regulate in trauma. So just all of you, we've all already kind of done this today, but thinking about the activation of your nervous system. So if you think about something frightening to you, for some people it's public speaking, think about getting in front of a crowd and having to speak, or hearing a loud noise, or usually I can get people when I say think about spiders, snakes, rodents, something like that that's disturbing to you. Just notice what happens just when I say that. This should not be like a major overwhelm, but just how did you respond? What happened inside of you when I said snakes, public speaking, dentist, rodent, spider, what's happening inside? And a couple people just share. Tightness, yeah, tightness is that sympathetic. I'm getting ready to fight or flee. Okay, tightness, good. What else? Yes, digestion just kind of like, yeah. And that, there's a whole lot that happens there, but it could be like a cortisol shot to the gut. It could also be the way the body sometimes responds to trauma in order to escape, is that all the energy will go away from digestion into the extremities, hands, feet, to fight or flee. And so sometimes it can be that quick. Yeah. Others? Heights, great, that's a good one.
me a strange feeling about jump or not to jump.
Yes, lots of people
I don't know
have
how to
this.
explain it.
Yeah.
It's so scary that you think that the only thing you can do
Is jump. Yeah, I've heard this from many people. I have that kind of same reaction. But that tends to be kind of, was it kind of here? Is it kind of here and up here? Yeah, it's that response. Yeah, that what am I gonna do about it? Yeah.
I think also with heights is like just the legs get wobbly or
Yeah.
something, like feeling like I don't know.
I'm gonna pass out, or like I can't hold myself up, like everything's wobbly. Yeah. So mostly that's sympathetic. Now, if we took it a little further and got a little more extreme with it, some of us would go into a dorsal response, like maybe with heights where you just kind of go, can't, or needles. I used to do that with needles, like, you know, got a lot of EDR, worked great. So, so that would be, you see how almost all of us go into hyper response first, that sympathetic arousal response, totally normal. That's how we've lived so long. And then some of us, if that threat continues to happen, we're gonna go into shutdown, hypo. And that's where we see our clients, sometimes our clients get to that point. Okay, so I think I've talked about this a lot already, but what you might see in some of the people you work with, you might think like, dang, they're just mean, but they're not mean, they're reactive. And so they might be argumentative, that's part of the fight response. So if you think of argumentative, loud, yelling, coming at you as part of the fight response, their arousal, their autonomic nervous system is in hyperarousal. Just kind of think of it that way, it might provide a little bit more compassion. And so how do we work with this? And this doesn't just have to be therapeutic interventions here. I'll get more to therapy models in a minute, in a few minutes, but think about how you can help anybody who's in this situation. One of the number one things, and I'll have you all do this right now, is just put your feet on the floor and press your feet down for a minute. Just press your feet down and wiggle your toes. This actually helps both with hyper and hypo activation. It's grounding. That is the definition of grounding, is noticing yourself in relation to gravity and the ground, and the earth. That can be one of the quickest things to do. So feeling feet on the floor. Sometimes I'll have clients just notice their bodies, their somatic system. So hand on belly, hand on heart, and then breathe in a way that you can blow up a balloon in your belly. That's a weird sound. So, you know, kind of taking a deeper breath can be useful. And one of the key things that the polyvagal theory kind of outlines and has brought to therapy world and helping world is that exhales being longer allows us to go into a parasympathetic rest and digest state more easily. So when we think about breathing exercises we might do with someone, asking them to breathe in for maybe a count of 4, and then breathe out for a count of 6, 7, 8, if they can, that is going to trigger a parasympathetic response, which is a calm, a rest, and a digest. Movement-based regulation is helpful with both hypo and hyper kind of arousal. So walking, it's one of the reasons why it's almost never a bad idea to go for a walk. We tend to feel better. Stretching and shaking. So this is a big one, again, comes from somatic therapy world. Again, if you see in nature, if you saw that gazelle and the lion again, and the lion attacks the gazelle, and let's say that it, you know, plays dead, the predator loosens its grip, gazelle runs off. What you'll see is as soon as the gazelle gets to a place of safety where the lion's not after them anymore, they will shake just completely all over. You'll see this in the animal world all the time. You sometimes see it in humans. And I've been studying trauma for a long time, but I remember giving birth to my first son, which is now 21 years ago almost. And I had a very long and dramatic, intense labor with him. But afterward, nobody had told me that my whole body was gonna shake. And like my whole body was just kind of like shaking and doing this thing. And I'm like looking at my midwife, going, what is happening? She's like, it's just shaking it off. You know, there's chemical reaction going on, but it's a version of kind of shaking off that trauma. So we do it naturally when we allow ourselves to, but as humans, we've trained ourselves out of doing that because it makes us look weird. You know, animals don't care, they just do it. But if we can train ourselves back into movement and shaking, that's why dancing and drumming can be really like healing modalities in a lot of different places. That's part of that shaking out the trauma. And then co-regulation. And so that's with another person. So Bessel van der Kolk says that most of us, when we're hurt, are hurt the worst in the context of relationships with other people, caregivers, whatever it might be. And we actually heal the best in relationship with other people. So we're hurt the most and we heal the best in the context of relationship. And that's one of the reasons therapy works. And human contact works. Not always, it can be really hard for a lot of people, but tone of voice and eye contact and calm presence, just being with someone, can actually be some of the most healing things you can do without saying or convincing them of anything. So then we look at that dorsal vagal, that shutdown, that's the numbing and the disconnection and dissociation. We get a lot of hopelessness in folks with this, checked out, difficulty accessing emotion. They'll look at you and just say, I'm fine, everything's fine, I don't feel anything. You know, that's not a normal stress or trauma response. I mean, in initial shock period, it can be, but afterward, it's a survival strategy that's gone too far, and it's now depressing the whole system. And that very numbed feeling, most people will like it for a while, and then it will start to cause problems in their life, and they'll come to therapy for it. So with this, what do we want to do? Movement, again, is super helpful. So those of you who are therapists, you know, what we're trained to do in grad school, we learn all these classes and all this cognitive behavioral work or whatever, where we just sit with our clients for 50 minutes and just sit and talk. And when somewhere along the line, probably after my MDR training, I started learning about, you know, somatic interventions and things like that. This makes so much more sense. And it helped my clients so much more. Just even standing up. I do this with almost all my clients at some point. If they're going numb, dissociative, things like that, I'll just say, stand up for a minute. Let's just stand up. I did this yesterday with a client. And all we did is we just walked back and forth in the room for a few minutes, looked at each other, kind of naming the room, the spatial, and then sit back down. It's a game changer in the room. So we don't have to just sit there. Rocking and stretching can be another thing. So sometimes I'll just have my clients, I'll just say, can you like act like you're yawning? Just that, and do like a little stretch, or even start to rock. And you'll see people with their legs and, you know, hands kind of going. I will encourage that, especially if they're going into numb dissociative. Let their leg bounce, let their hands fidget, and increase that movement. One of my other kind of favorite present orientation activities is 5, 4, 3, 2, 1. You probably, many of you have do this or heard of this, but I'm just going to ask you all to do it right now, just so you get a sense of what's happening here. Essentially, what we're doing is we're asking the autonomic nervous system, the sensory input, to be named and observed. It puts us kind of in an observing self place and allows us to not get stuck in the past or the trauma or that shutdown response. So I'm going to ask all of you right now, I want you to just look around the room and in your mind's eye, name 5 things that you see. Okay. And now I want you to actually, I'm gonna do a little pendulation here with you. I want you to think about something that's like super mildly disturbing. Like you were running late today, you lost your keys, the traffic was a little stopped up, there was some construction, you know, you couldn't find your favorite pair of shoes. Really mild, no trauma here, okay? Just get a little irritated, okay? And now I want you to touch or name in your mind's eye 4 things that you can touch. Okay. Okay. Now go back to the other set of these. There were fresh batteries, but hang on just a second. Not the best time to lose the mic, but we're gonna roll with that. Uh-oh. So there was another set. So weird. I swear I showed them here. Yeah, just let them know the battery died in that one. I lost it. Thanks. Okay, so sorry, this is totally not the right time for this, but now going back to that disturbance, that little irritation. Hey, this one died, and I know you showed me I had another one, but I can't find it now.
Oh, sure, no problem. Sorry, guys.
Oh, over there. Oh, the drawer. Forgot about the drawer. Thank you.
You're
A little bit of irritation, and then go back now. Name 3 things you can hear. Just focus on 3 things that you can hear. And notice what shifts there. And then go back to the little bit of irritation. And now notice 2 things you can smell. It's like name or notice 2 things you can smell. And if you have like lotion or a piece of fruit or a mint or something, actually put that up to your nose. All right, and then back to the little bit of irritation. And now if you have something to drink in front of you, I want you to just take a sip or use a mint or gum or something that you can taste for a moment. Doing that. Okay, oh, we're back online. Thank you so much, appreciate it. Okay, so that's 5, 4, 3, 2, 1 with a pendulation to slight irritant, okay? So, did everybody notice that I mean, I know it was a little disjointed there, but that can shift a little bit? That's a skill I want to teach my clients. I'll start just with the 5, 4, 3, 2, 1, then sometimes I'll start adding in something really, you know, just slight irritation. I do define slight irritation for my clients because I swear this has happened before. I'll say, if you think of something just really mild, like, you know, 1 or 2 on a 10-point scale, and somebody has said like, oh yeah, when my dad died, the dad died last year. I'm like, that is not a 1 or 2. You know, I'm talking about like Starbucks had a line this morning, or like, you know, you lost your keys or something. Okay, yes, Lily.
Someone asked, would you consider bilateral tapping a somatic intervention to pull someone out of dorsal vagal?
Well, I'm an EMDR therapist, so of course. The question is, would I consider bilateral tapping as a somatic intervention to pull someone out of dorsal vagal? Okay, I'm going to revise that. Just when I hear bilateral tapping, my heart gets warm because I'm an EMDR therapist and I love EMDR so much. So bilateral tapping, yes, can be very, very useful. Does it always pull people out of dorsal vagal? No, it doesn't always. So I would not use that as my primary. I would use other things. I would stand up, I would move around. I would do something kind of active oriented first, and then when they get back to present, I would add bilateral tapping. That really depends on the client. I work with some pretty dissociative people, so that might be where that answer comes from. I think it could work, but not always. So longer exhales, I've already talked about that. Now again, with numbing, we want to bring sensory information in when we're shut down. And so things like weighted blankets, I don't touch my clients without consent before they're dissociated. And even then, I'm pretty cautious about that. But having them touch them, you know, kind of give like a felt sense to their body can be helpful. One of my favorite things to do there is to have them, you know, kind of rub their hands and kind of create that heat, and then put that heat on their skin, on their face. That can sometimes be useful. And then really slow engagement, like I'm right here with you, rather than you're kind of overwhelming them with information. But you saw me in the 5, 4, 3, 2, 1 do some of the scent and the taste thing. So this is part of the brain stuff that helps in trauma. Scent, the aroma, skips the thalamus when it goes into brain sensory input. And so it can be one of the fastest ways to ground someone. The only thing is with trauma survivors, scent is also highly activating and triggering at times. So you want to establish scents that are okay for that person before they're in a shutdown phase. So if I have essential oils, I want to know which one is their favorite, you know, peppermint, lavender, whatever it is. Or like I always have mints in my office, or gum, or if they have their coffee drink, you know, if they have smelly lotions, things like that. I'll ask them first, do you have your lotion with you? Do you have a mint, something that they have on them, to be able to get that taste or that smell? And then taste, when we do the act of swallowing, it automatically sends a message to our nervous system that we're in safe enough space, because we can't swallow well when we're activated in serious threat. So swallowing a drink, or even just the act of swallowing, if you don't have a drink, can really calm the system and bring them back. One of the other things I like to do when somebody's shutting down is playing catch with something very soft. So I have pillows on my couch, and I'll say, can you just toss that pillow over here, and we'll just toss it gently back and forth. We all have tissues in our office. If we're therapists, most of us have tissues. I'll ball up a tissue, and this is pretty cool because it's hard to catch a tissue actually. So I'll have my client in front of me and I'll say, I'm gonna toss this toward you, can you catch it? You'll see how it kind of floats. So in order for them to do that, they have to have some spatial awareness here in the present. I'll even do that on virtual sessions, and it's really funny watching. I like doing that. And then the last piece I want to talk about is therapeutic models. Now, I want to first say I am super biased. Okay, so like naming my bias here, I love EMDR, and so I'll talk about EMDR all day. I literally teach EMDR like all the time, so it's my favorite thing to talk about. So I will be open. If you don't like EMDR, that's cool. We can talk about that. But I'm a little biased there, and IFS. Those are my two favorite therapeutic modalities. I'm trained in other things. Those are just my favorites. So I'm just gonna put that out there. Okay. But when we go into therapeutic models, thinking about how we're trained as therapists and in therapeutic settings that we're trained in grad school and things like that, we have kind of loosely what we would call top-down interventions with trauma models, and then bottom-up trauma intervention models. You'll probably guess that I'm really into the bottom-up interventions, but let's talk about the top-down first because they do work. They don't always work with trauma survivors, but they do work with many people. So higher order kind of cognitive behavioral therapies and cognitive thoughts are those top-down ones. And here's the mechanism of how those work is that they're accessing the prefrontal cortex and the higher functions of the brain and changing thoughts and beliefs here. And then the idea there is that trickles down and helps us regulate our emotions and our somatic responses and things like that. It can work, it can, sometimes, okay? But we want to engage that prefrontal cortex. And I say that with trauma because trauma is what I deal with all the time. So if you have somebody who's coming in for things other than trauma, it can be very, very effective. So that's our CBT, trauma-focused CBT. DBT, skills-based. Now I know a lot of the DBT skills do have somatic elements, so there's other pieces in that. Acceptance and commitment therapy, that's a third wave cognitive behavioral form of therapy. Prolonged exposure, there's some elements of, you're exposing them, but you're mostly exposing them to the story, the narrative. The hard thing about this with trauma survivors, especially extreme trauma survivors, is that they don't actually have access to the narrative very easily. Their prefrontal cortex was offline during the hardest part of what they've experienced. And it's very hard to gather that narrative, gather that story, and do all of that. So cognitive processing therapy, also similar. I put IFS on here only because it's more of a hybrid. And there's debate about this. I mean, there's nobody who's like an expert on all this perfectly. There's a bit of a debate because IFS is more talk oriented, but there's a lot of somatic intervention there. And there's this kind of different form of psychological distancing that we do in IFS, so it can be kind of both places. Then we have our bottom-up interventions. And what we mean there is that instead of trying to engage the prefrontal cortex first, we want to engage body and lower kind of like limbic area functioning. If we can reach that first, and we can affect change on that level, then what happens is we feel a somatic change or an emotional change, and then our thoughts kind of naturally tend to shift. And we have a different perspective on the world. Now, we sometimes have to work at that, and integration is always going to be your best bet there. But, sensor and motor processing rather than cognitive. So usually we're accessing body and limbic brain places to do this. So we're regulating the nervous system. We're talking about subcortical. So cortical, subcortical, that's where we're going with these forms of therapy. Body awareness, movement, sensory integration rather than cognitive stuff first. Now, it's so funny because I actually have I'm a super left brain person. Like I have people in my life, a lot of people in my life who are neurodivergent, ADHD and things like that. And they're like, I have an extremely neurotypical brain in the sense that I love to plan, I love to think, I love to talk, I love words, I love stories. I was an English major undergrad, I can think and talk through all kinds of things with people, and I love it. That's like a comfort level for me. But when it comes to therapy with my trauma clients, I just think this is where the real change I have seen with my clients happens. And that's the somatic experience. I'm not trained in somatic experiencing or sensory motor, but I use a lot of those elements that I've picked up over the years in various trainings and workshops in conjunction with other types of therapy. Coherence therapy, I'm going to talk more about in a moment, which is really about memory reconsolidation. I've got more on that. I'm probably a little bit behind here. Okay, EMDR, you've heard me talk about that. If you don't know what EMDR is, actually, I'm going to talk about that in a minute. Psychedelic assisted psychotherapy. This is frontiers of therapy here. We're in a new frontier of therapy with psychedelics, and I can talk about that. AEDP, accelerated experiential dynamic. I'm not as familiar with that. It's a lot of being with. It's a lot of co-regulation from the therapist. It's a lot of slow, I'm right here with you, connection, rather than trying to cognitively restructure. And then IFS, as I mentioned. But what I want to say about the therapies that tend to be very effective with trauma is that they have an element of memory reconsolidation in it. Memory reconsolidation is a neurological process of change in the brain. And I love this work, and I don't know why I didn't put this on the slide here, but this comes from Bruce Ecker, E-C-K-E-R, Bruce Ecker, and Robin Tickick, T-I-C-I-C. Their work, they have a ton of research out there. They've written a book called Unlocking the Emotional Brain, which is all about memory reconsolidation. And this is less a form of therapy than an underlying foundational way that therapy works. So it's a natural process that we actually all have inside of us, which is where we have memories that are stored that we can then pull up into our recall part of our brain and look closely at and have a different experience of safety and connection, things like that now, and then update, edit, or change those memories and restore them in a different form in the brain so that our brain-body systems update to the current situation. So this is called emotional learning, and it's a transformation, not just suppression. So sometimes the problem I had with really strict CBT work, cognitive behavioral work, was that it was a hell of a lot of work. It was a lot of convincing. It was a lot of like, now look for all the images. Okay, look for that again. Now let's find that thought again. Now let's find the alternative. Let's do that again. Now go practice it. Like, that's a lot, and it's a lot for a trauma survivor to do. If we can get into the activation, the emotional learning place of it, where you feel that in your body, what's happening there, we open that memory. It's activated. We do have to activate it. And this is where cognitive therapists have a harder time because they're like, I don't want to activate my clients like that. I'm staying away from activation. But actually what memory reconsolidation says is activation is pretty essential to the change process in trauma work. So we activate the memory, we open it up, and then we're going to introduce a juxtaposition or a mismatch of information that's going to help the brain system kind of update from there. So this slide did not turn out as well as I wanted it to. I lost my numbers. But reactivation is the big part of this. So if you think EMDR, IFS, psychedelics, coherence, all those kinds of things, we actually are triggering our clients. And this is where sometimes the cognitive folks are like, that's not helpful. It isn't and isn't. I mean, it depends on the person, but mostly it is, as long as you are doing this with a goal in mind that we activate, and then we are opening that memory network in the brain. So we're opening a window of plasticity in the brain by activating that memory. And then we're updating that by helping the client have a felt sense of new emotional learning. Part of that new emotional learning is, I'm right here with you, and we are safe right now, which you can't convince someone of that, but we can introduce that juxtaposition. We can then have them experience other times in their life or other emotional sense of when they have felt safety, calm, positive affect, positive, thoughts, things like that. And that can then update that memory, and then it can be rewritten and restored differently in the brain. This is what you've heard many times called the plasticity of the brain, neuroplasticity. We have the ability to change, especially memories. There's debate about this, but general window of change, malleability, plasticity is around 1 to 6 hours after we have activated a memory. So when we say activate, we're actually pulling that up, asking them to go into as much of the sensory felt sense of it that we can without getting outside the window of tolerance, which is a fine dance. That's an art therapy. And then we have, 1 to 6 hours after that where we can update that memory. As long as they're in the window of tolerance, we don't want to overdo it. Okay. And what memory reconsolidation research says is that there are some therapeutic models that do this much better than others. And here's a few of them. This is not exhaustive, but coherence therapy is actually built off of the memory reconsolidation research. It's Bruce Ecker and Robin Tickett's model of therapy. It is very cognitive in that you're talking through things, and there's this kind of felt experiential sense of emotional updating, which I'm not going to get too much into, and then these others. So I'm going to briefly go through this because I know I'm running out of time. But our concept here is that once we've established safety and connection with our clients, it's not like the first session they sit down, we're going to do this. We establish safety and connection, and then we access and activate memories that are troublesome, bothersome, that have created some emotional learning for this client, for this person, that has a deeply felt emotional truth to it, okay? Like a belief that feels really true and a sense in the body that feels really true without trying to fight it. And that's going to be the key with all these therapeutic models. It's an acceptance of that feeling and that truth right now. And then we create a mismatch experience, either contextually within therapy or outside of therapy, where there's an experience of felt safety, connection, not being harmed, things like that. And that can update that memory. EMDR is similar. I just think it's a super beautiful model of therapy because it takes like elements of just about every type of other therapy and puts them all into one, and including like cognitive restructuring, somatic work, we go to the body. And then we add this weird thing called bilateral stimulation, which you'll often see as therapists moving their hand back and forth like this. But we have lots more ways of doing that with buzzers and tactile and auditory. But the bilateral stimulation is part of that change agent that helps the juxtaposition experience. So once you've created that mismatch, you've activated the negative memory, you've also activated positive sense of self and all that kind of stuff in the same time, you then add the bilateral stimulation and the whole brain works on the problem subconsciously. So what I tell my clients is, we can do some stuff here when we're talking about it. EMDR gets here, below the talking, subcortical, okay? So that's where it can really be helpful when we've talked it all out as much as we can. IFS, how many of you have seen Inside Out or Inside Out 2? Okay, that's why I put that there, because almost everybody's seen that. It's very IFS-y, okay, that there are parts of us in the brain, you know. Now, I personally don't believe that there are little parts of us running around. I know some people in IFS world believe that, but it's neural networks. It's memory networks that are lit up that we can call parts of ourselves. And as soon as we say that, like let's say that we're really feeling very angry. If I say a part of me is really angry, that feels very different than I am super angry. Can you see how that feels differently? Just even saying a part of me is really angry gives me that psychological distance observing self to be able to say, yes, this part of me, but not all of me. Now, some clients will argue with you about that, but there's a lot more to it. But our goal here is that we activate this emotional sense, this memory, this experience we've had, and then we get some psychological distance from it, a little bit, without trying to convince, and we do it in an accepting way of, yes, let's bring that anger a little closer, let's understand it, what's its function, why is it doing what it does, that makes a lot of sense, let's be with that right now, is there anything else it needs you to know, is there anything else you need to know, and you're really getting to almost interviewing the parts of self. Very simplified understanding of that, but that creates that mismatch that happens in memory reconsolidation. Somatic experiencing, we did one of the little things there with pendulation when we did that a few minutes ago, where we did like little irritation, now come back to right here, little irritation, now smell some things, little irritation. That's pendulation, which is very commonly used in somatic experiencing work, but it's grounding in safety and body awareness, movement, mindfulness, and pendulating between negative and positive that allows for that mismatch experience that memory consolidation can have. So also allowing the body to move through something rather than what typically happens during trauma. We have something that happens to us, we go into tense, fight, flight, or collapse. We don't finish the movement. And then, so when we act that out in therapy with somatic experiencing, we can actually let our bodies discharge some of that movement and activation. So that can be helpful. Now, I could also talk about this all day because I'm super interested in it, because I think this is the wave of the future with therapy, which is psychedelic assisted psychotherapy. And part of the reason for that is because we've got the research is happening right now extensively around the world on what happens when we introduce a psychedelic substance into the brain. It seems to open this window of neuroplasticity so much more efficiently than talk therapy and all that kind of stuff. So we can open that window of plasticity, and then we can update things while we're in there. And the brain does it itself, really, a lot of the times. But doing that alongside psychotherapy is shown to be much more effective than trying to do it when you're just like throwing some MDMA back and going to the party club, you know, or whatever. That's very different than, you know, doing like an MDMA session, which is being studied in trials all over the world right now. For trauma in particular, MDMA, short for ecstasy, Molly, that's how they name it in club drugs world, but this is different. This is pure MDMA, and you're doing it in the context of therapists. It's a 4, 5, 6 hour session where that window of plasticity is open the whole time, and therapists are working with you with your trauma memories to update them. So it's pretty cool. And then here's, yay, I can finish on time. Here is the key. None of these works completely on their own for everybody. And so any survivor of trauma, we're going to integrate our methods of, you know, regulating and our models of therapy. One therapeutic model. I used to think EMDR could do it. I would have fought to the death on that probably 15 years ago. But I've learned the hard way that it's not true for every single person. That really integration with various models of therapy is going to be your best bet for any person sitting in front of you. So we're all, you know, humans with different brains and bodies and all that kind of stuff. Okay, that was a whirlwind. Sorry, threw a lot at you. Okay, so we've got like 5 minutes for questions, and then I know maybe Linda's going to come up and do a little thing too. But any burning questions, anything I didn't get to that felt like would have been more helpful? Yeah.
I kept thinking about like OCD.
Yes.
And like, could you just touch on a little bit more of like how trauma can really activate that? Like,
Yes.
maybe
Yeah.
something.
I'm going to try and simplify that, but the question is about OCD and how trauma can impact that. So OCD we know is highly heritable. So it is most often found in family systems genetically going down through the genetic line. But sometimes what happens, and there's a whole thing about like epigenetics, you can study all that stuff about how genes turn on and don't. Sometimes in families you have that OCD kind of gene there, but it doesn't get expressed because nothing kind of turns it on. But trauma has the ability to turn on gene expression for things that are like lying there, like sometimes psychotic disorders and, you know, OCD and things like that. So trauma is often linked as like, oh, did that cause the OCD? It can. There are cases where trauma itself can create an OCD response, but more often that genetic marker was kind of there and trauma turned that switch on, and then now it becomes, you know, kind of a problem. So what I'll say about this, there's a huge debate in the EMDR world around OCD right now. I'm not touching that with a 10-foot pole, but it is true. EMDR is not evidence-based for OCD, although it's becoming closer. So ERP, exposure response prevention, and inference-based CBT are kind of the go-tos, the gold standards for treatment of OCD. I think EMDR or trauma therapies can be very, very useful in conjunction integration there, especially when there's a trauma turn on or kind of a trauma genesis of something there. So when you can treat, yes, you need to treat the symptoms with therapies that are marked for that, but also you can have a big impact when you work with the trauma thing that turned that thing on. Might not eliminate the symptoms, but can really, really help. So yeah, does that make sense?
Yes.
Okay, cool. Yeah.
For EMDR, you talked about how for some people like that going beneath and like activating the subcortical,
Right.
or activating the subcortical is really important. What about for people who have trauma and they have like completely just like kind of, I don't know, I feel like some people maybe like disconnect from their
Yeah.
body
Yes.
and they have a really hard time accessing
Yes.
that part.
Yes.
Does it work for those people?
Yeah.
Or like how does it work differently?
Great question. So how does EMDR work with people who are basically shut down, hypo-aroused, and living in kind of this disconnected, dissociative state rather than the hyper-activated? it is harder and is more complex, and it requires more integration with other types of therapy to do that, because the activation of the memories, the activation of the trauma material is like, they're opposed to everything about that, you know, like every part of them is fighting against that. That's where I bring IFS in. So I bring IFS in to work with the parts that are shutting you down, and we work with that and get to know those parts really, really well. And then once that happens, those are called protector parts. Once we're able to kind of get permission from those protector parts, psychedelics can do this too really helpfully, and probably other things too. Those are just my methods. Then I'm able to activate the trauma in the window of tolerance where they can tolerate it. They're not trying to suppress it again. Then we can do some EMDR work, but it takes integration. That's where I said, like, I used to think EMDR could do it all, but when you have high levels of dissociation, it can't. You have to do all this work first to get there. Yeah, great question. Others? Anything online, Lily? We good? All right. Well, Linda's gonna come up and I'm gonna sit down and shut up. Thank you all so much.